So just give one second for folk to leave and join, and then we'll...
No worries. Hopefully everyone can hear me, I think so. So I'll keep this brief because it's approaching the lunch hour. Excuse me, I'm Rob Watkins. When we did this piece of work, I was working at LLR ICB, which is Leicestershire and Rutland ICB. I'm currently working in Staffordshire and Stoke-on-Trent, so I've moved 30 miles west. Poor geography to start with. So this was a piece of work we were asked to do as a small group of us to look at levels of A&E activity for paediatrics due to increasing demand on services, particularly at University Hospital Leicester. And we were asked to do some analysis to see whether there was inequalities aspect to it, looking at deprivation, ethnicity and certain other key indicators as well. So this was basically the brief, just to understand where there was variation, geographical, whether that was linked, as I said, to inequalities. Try and understand maybe by linking into other data sets if we could, just to see what the patterns were in terms of activity. So it was over about 6 months. It was a small working group, myself, Adrian, who sat over there, 3 consultants from University Hospital Leicester, as well as public health experts from Leicestershire County Council and Leicester City Council, and ICB as well. So it was like a multidisciplinary team. So this is my attempt to try and show the data flows. So effectively we used ECDS. For those who don't know, that's the emergency care data set. We picked 1 year's worth of data. We picked out all residents living in LLR down to LSOA and MSOA. For those who don't know, that's basically geographical areas that they use in the census, LSOA being very small and MSOA being probably big enough to map, so we'll come on to that shortly. Worked out what the deprivation was, used the population for 2022 from ONS to MSOA to work out rates per thousand. We just did crude rates, so I didn't directly standardise it. We also used the what we call the MPI spine table, which we had access to in the CSU, which is effectively a register of all registered patients by GP. So from that, you're also able to derive your denominator based on deprivation ethnicity, which was useful. And then we had some outputs. We also linked in the ED activity to the maternity data set, which is the MSDS, for those who use it. So we linked the baby or the child's pseudo NHS number to the pseudo NHS number in MSDS. And from that is a link where you're able to get the mother's details, because obviously for most children, they're not the ones who decide to come to A&E, particularly for young children. It's assumptions that obviously we get the mother's details, which again, there's an assumption obviously because it might not be the case, but it gave us some ideas of demographics of the mum bringing the child into A&E as well. So just a bit of context. In LLR, I don't know if anyone's familiar with the geography, but the main A&E department is Leicester Royal Infirmary. It's a type 1 and type 2. There's some eye stuff there, which is type 2, but it's mainly, a 24-hour consultant-led A&E. And then we've got patches of other providers. In Loughborough, we had an urgent care centre. Now, some of these have changed. Anyone who knows emergency care knows that this is 22-23, and we've moved more to UTC models now for those in the know. So this has changed slightly, but the long and short of it is Leicester Royal Infirmary is the main player in town, but some of our localities, so for example, patients who lived in Hinckley would more likely to go to Nuneaton because it's closer, and then some patients might go to Covell, Rugby, and then some flows to places like Burton and Derby. So what's happened over the years in terms of activity for kids coming into ED? This is for all children. I split it by by age of child. Anyone who's looked at AD numbers before and rates will know that 0 to 1s are the highest rates you can get in terms of A&E activity. Then it goes down as you go older, and then it starts creeping up when you get to around 65 older population. So it's very much like a dip in terms of the profile of people coming to ED. We can see what happened during the pandemic. All the age groups dipped, and then we've come back up to pre-pandemic levels. In fact, in 22-23, we're above pre-pandemic levels. So I guess this is one of the areas that they were keen to look at to understand where change had happened. We did some very quick analysis in terms of looking at different local authorities. These are lower tier local authorities across the West Midlands because we have the data working in the CSU, just to understand the comparative rates. And the light dots, or yellow, are the LLR local authorities. There's about, I think there's 9, so Leicester, Rutland, Oadby, those and surrounding areas, Hinckley. And you can see, effectively, the one on the left-hand side shows that the local authorities with the highest type 1 or type 2 rates are also the ones with the lowest provision of what we used to call type 3, which is Urgent Treatment Centre, or UCCs, which kind of makes sense because there isn't one there for them to go to, so they all go to type 1. And that's the case for Leicester City, and that was one of the things they were interested to look at to see how they compared. Conversely, the one on the right is what I call the build it and they will come chart. It's less of a strong correlation. You can see, though, overall rates tend to be higher in areas that do have type 3 units. Where I'm working at the moment in Staffordshire, we've got 2 MRUs in South East Staffordshire, and if you look at their rates for South East Staffordshire, they're some of the highest rates of A&E activity in the country. So it's just to give a bit of context around that. So we did some clever mapping. I say clever mapping, Adrian did it in Power BI, and we worked out what the rates were by MSOA. We applied 95% confidence intervals to the overall LLR rate and MSOA. So if the lower confidence interval rate was higher than the LLR upper confidence interval rate, we marked it as red and vice versa. So the first one shows type 1 activity, which is very much concentrated around Hinckley, for those who know the geography of LLR, and west, south and north Leicester, but less so east Leicester. We'll come on to that shortly. Then conversely, if you just look at type 1, there's type 3, which is the middle one, very little activity around Leicester Centre and Hinckley because there is no type 3. And I guess the one we used to concentrate on was the one on the right-hand side, which is the 2 combined, which again shows clumps of high levels of activity around Loughborough, which is right at the lump at the top. And then you've got west, south and north Leicester and Hinckley. So we kind of use that as an area, as a way to sort of target what we were looking at. Just to give you an idea of what we're talking about with deprivation, because obviously a lot of this is linked to deprivation, or that's what it shows. The one on the left-hand side is what we call the core 20% most deprived LSOAs in England. Mainly clumps, if you can see on the map, round north. West Leicester, places like Braunstone, Aylestone, South Leicester, where there's quite large estates, and a few clumps in East Leicester. You've got a lump around Colville, which is an ex-mining area in the north, and a little bit in Loughborough. Other than that, there's not much else in LLR. And the map on the right-hand side shows it by MSOA, but doing kind of like a weighted based on the LSOAs who lived there. So it just gives you an idea that how it's mapped. There's a lot of data on here, so I'm not going to go through all of this, but effectively then we looked at Leicester specifically. So we have done this analysis for Hinckley and Bosworth as well as Loughborough, but I'll take you through the Leicester stuff only because just to save time. As you can see, the heat map on the right-hand side shows a clear split between West, South Leicester and East Leicester. If you look at the areas which have the highest rates across all age groups, so I'm going to pick out Braunston Park West, you can see 100% of that population is in core 20. But interestingly, these areas on West and South North Leicester have a lower than Leicester rate of ethnic minorities living in them. If you know Leicester at all, you'll know that parts of North Leicester and East Leicester have got a high proportion of ethnic minorities, which made it quite interesting. This is something I shamelessly stole from the PHE. It's a tool they use. I put some numbers in again just to look at the deprivation score and the rate per 1,000. So you can see that it comes out with some numbers. I'm not a statistician, so someone will surely tell me, if that makes sense or not. But yeah, so we put that in. Then I did some charts here. So the one on the left-hand side shows the rate per 1,000 for Leicester by deprivation. So the 5 quintiles, core 20 is the one on the left-hand side, and you can see it's much higher. We also did the same by deprivation, and you can see that actually it's the white population and another whichever rate above Leicester. And then the kind of heat map on the bottom left-hand side clearly shows the relationship again that core 20 areas, regardless of ethnicity, have a much higher rate of attendance in A&E. And overall, as we've seen in on the chart, you can see that the white population as well. So so that was something to go on. Lots of data. I'm not going to go through this in too much detail. What I'm trying to show here is the one on the left-hand side shows the rate by MSOA in Leicester. So you've got some high ones, you've got some low ones, you've got some in the middle. But also on the right-hand side chart shows the proportion of the population attending ED in that given year. So what we were trying to understand here is there's a hypothesis that high attendance rates was generated by small numbers coming in a lot of times, which isn't the case. The areas generally which have the higher rate of activity have a higher proportion of the population attending. So it is generally split there equally across the population. So it is a population thing rather than an individual thing. And this is the average number of attendances per year for patients attending. So this is for under 18s, and you can see there is little variation by MSOA. So the hypothesis that it's small numbers generating it's multiple attendances doesn't seem to run true. We also had a look at, we looked at loads of data, but I'm just picking out the main ones. We looked at those coming in with no investigation or significant treatment. So we basically used the HRG code, and we know there's some issues with A&E code, and there always was. But these are effectively patients where it didn't look like they came in, they either left without treatment or they didn't receive any kind of treatment or investigation whilst there. Again, you can see that the rates are much higher, but for core 20. Interestingly, we looked at the age of the baby as well, and it is young babies coming in a lot higher with the rates where they're coming in for advice and guidance, but not necessarily receiving any treatment. So again, that gave us a bit more information on the kind of sort of areas we were looking at. This one was another one which kind of links to the previous one as well, and this is based on some work that was done in other areas. We had a literary search. One of our public health consultants did some work around looking at other works around this, and we linked the age of mum to the attendance rate, and you can see the rate. We put 95% confidence intervals in, as you can see. You can see for mums who are under 19, a much higher rate. So it is younger babies and it's younger mums that are coming in. And when we have looked at that geographically, they are based in the south and west Leicester localities as well. So again, that fed into some of the conclusions and some of the actions that the ICB are taking forward. I'm not going to go through all these. These are some of the recommendations that the group came up with. They including creating a dashboard around health inequalities for clinicians to use in ED. I think that's something they were quite keen to take forward. Maybe looking at some of the provision in terms of health visiting across the city. And there's some longer term stuffs around understanding whether some other environmental sort of things affect the numbers. So it's in its infancy. Obviously I've left LLR now, but I think they're taking it forward as a starter for 10. There's loads of stuff that we did that's not in here, but I just thought I'd pick out the main ones. So I rattled through that quite quickly, but I'm happy to take any questions.
Thank you very much, Robert. Yeah, we are slightly ahead of time, so there is space for questions. We've already got one. I'll walk down while you look at the online offerings, Lucy.
Thanks very much. Hopefully I won't start coughing. The aircon's getting to me now. I'm Sarah Parsons. I'm Health and Research Lead at an organisation called HACA, which is the Housing Association's Charitable Trust. I want to thank Rob, yourself and the other presenters that we've heard. More of an observation than anything else, although if you do, please do comment if you can. I noticed in all the presentations, though, Rob, there was actually a 3-letter acronym there of EPC, but the lack of reference to social housing on health and health inequalities and the impact on health at the moment. EPC, I'm sure we all know if we live in homes, it's the energy performance certificate, and actually that's not really, we normally say anything below a C, impact. Actually, it doesn't really tell you anything about the inequalities, because you can live in a lower performing EPC house, but you might be able to pay the bill, so that doesn't make any difference particularly. So yeah, my concern's really that, are we looking at, particularly at social housing, and what a problem this is, because I'm going around with eagle eyes looking at posters and what have you. I don't know if there's anybody in the room from the Black Country here. If so, big up, because Black Country ICB have got a massive focus on that at the moment. And looking at A&E or ED attendances in the 23-24 period, A&E attendances attributed to those living in social housing, wait for it, was 95%. Okay, so I just think there's a massive gap here that people aren't talking about, or are you, but you've just not had time to share data?
No, that's a very valid point. And to be honest, when this project started, it was led by a respiratory consultant whose view was it was linked to housing and levels of pollution. So the issue we had was getting that data to link to the data source. So we are working, or they were working with local authorities. The initial stage was to understand the high level stuff, but what we wanted to do was link to levels of pollution and things like home smoking and scent, but also social housing as well. The way the data set, once we move out of NHS data, as people know, it starts getting a bit difficult. So that's the ultimate aim, to be able to do that. And absolutely, social housing is a main issue, because of those people who know Leicester, those areas with the highest levels are basically mostly, from what I'm aware, social housing estates that were built in the 50s and 60s.
Yeah, and a big ask for data people in the room. In the work that we do in tackling health inequalities for people living in social housing, the biggest problem in the projects that we work on is getting health to share data with housing. Getting past that agreement, it's so difficult, and the best we can do often is to rely on the LSOA data. Yeah. But then you do have little pockets of really good stuff that's happening. In Walsall, for example, part of the Black Country, there's a great agreement between the local paediatricians when they get people with chronic respiratory conditions, young children in with asthma, that they will, if they know that child is living in a home that's social housing, they contact that social housing provider. Yep. And now that's brilliant, but that's one little pocket. We basically need to have a way of health sharing housing with data better. So that's a massive ask, guys. And if anybody's got any ideas or knows, please come and find me.
I'm not an IG expert, but I know it's a massive headache, even us sharing quite normal data sets with local authorities. I'm sure everyone around here has come across this. It's the IG rules, and it's getting over that. And I'm not an IG expert, but I know that some areas have done some really good work around this. I think Lincolnshire have as well. They've come up with something, so yeah.
A perennial problem. Lucy, any questions from Slido?
Yeah. We've got a few online. So one is about, have you explored how proximity, either by distance or travel time to the ED, might be a confounder with the other factors?
Yes. Yeah, we did look at proximity. So Leicester Royal Infirmary is effectively on the south of the city, and within quite close proximity there's very low rates, and within quite close proximity there's very high rates. So Knighton, for example, is quite an affluent area which borders the university, which is effectively where Royal Infirmary is, and they have low rates. There is a link with proximity, obviously, but we don't think it's the overarching link. We suspect it is due to deprivation.
And then there was another one about whether or not the mother has had a previous child or not.
We did do that as well, yeah. That's not on the slide, but we did do that. And I think from what I remember, because it's a while since we pulled this together, it was it was a high rate for when it was the first child. Yeah, so I'll put those in, I can put those in and we can share that. So.
Keeping fit, getting my steps into it.
Hi, I'm Freya. I work at the Health Foundation. Did you look at GP registration? Was there anything you could do about GP behaviours? Just thinking about people who are less likely to seek primary care and more likely to end up in secondary care.
Yeah, we looked at the rates at first by PCN and then down to GP level, because the PCNs in Leicester aren't geographically linked, so they're all over the place. So we did look at that. It generally correlated with the areas with the high deprivation rates as well. I did speak to one of the GPs who is in one of those practices and with the highest rate, just as part of a conversation. He said he was absolutely no surprise whatsoever that his patients were the ones seeking help in ED, and he wasn't on the defensive about it. He just said that is just the nature of the population they're serving. But we did do some analysis by GP as well, yeah, to see if there was variation in the rates, but they tended to correlate with the geographical rates where the highest levels are.
And sort of linked to that, there was one online about whether a lack of GP registration might have influenced.
Yeah, I mean, there's the inverse care law, isn't there? Are there some of the areas in East Leicester with low rates, we're assuming, because there is deprivation in East Leicester, and it's a high proportion of ethnic minorities. Is that because they don't feel comfortable seeking medical help? It's like the old RTT waiting list. If you look at the number of patients waiting, it tends to be more affluent patients are oversubscribed on waiting list. Is there the inverse care law? It's a good question. A lot of these are, I guess, with the next stage to look at analysis, and I think they were looking to maybe look at some sort of patient interaction. So yeah, as I say, that's where they were at the moment, but it's a very valid question.
Great stuff. One more at the back then. Should have had two people who were roaming mics.
Hi, Anita Charlesworth, and this question comes from being on North West London ICS. Can I ask a bit about the services provided by local authority? So are you able to look at health visiting? Because if this is under ones and the very early stages, obviously health visitors don't come out as an emergency service, but they should be providing some of the support and guidance and confidence building to manage and know how to manage sort of simple conditions. And so there's that, but also obviously there are, like children's hubs and all of those sorts of things which ICSs are thinking about. So those services potentially as important as GP?
Absolutely, yeah. So the health visiting one we did try to look at, and I think that was in its development of linking the community services data set to ECDS. So that was the next stage of the project, and to try and map what was in each area as well. Which is easier said than done. Health visiting is a bit easier because it's a normal data set and you can look at the contacts per population. I think that was the next stage of things they were going to look at. Some of the wider sort of services, like I'm going to say Sure Start now. I'm not even sure Sure Start still exists, but that kind of thing. We were going to try and map that, as well as obviously the stuff that we mentioned before, like where we've got urgent treatment centres, because obviously that's the new model of care. You phone 111 and they give you a slot. So understanding 111 as well. So it's just the next step on from the work we were doing. But absolutely, yeah, that's something they're going to try and look at.
Okay, that's great. Thank you again, everyone. If we could show appreciation for Beth, Tom, for Matt, and for Robert. Thank you.